It's a real pleasure to be here. I've had the honor to be at every one of these STOP meetings, and they keep getting better. The science, this is really one of the best prostate cancer meetings you can go to. It's well balanced, and congratulations to everybody that put it together. Bioscript always does a great job. There's my disclosures. Let's go. A lot of history in hormone therapy. As the first effective therapy for any cancer, an oral therapy, estrogens by Huggins, 2 Nobel Prizes. And then sort of when I grew up in urology, there weren't a lot of trials. There were the sort of the VA trials and the National Prostatic Cancer trials, you know, maybe 5 or 6. Now we have hundreds. But what we did learn from some of these trials are that estrogens have side effects. Even though they're a great treatment for prostate cancer, they have side effects. So we've been trying to deal with that for a long time. But we really didn't realize that not only estrogens, but other forms of therapy have side effects too. And this was the 3rd VA study. There were 2 VA studies before this, one looking at doses and then reducing the doses. And this is a group, the VA study group 3, that looked at men who were getting with locally advanced disease or localized disease that got some sort of surgical therapy, and they looked at on layering on orchiectomy or estrogens. And what was seen here is you got estrogens, you had a higher cardiovascular event, but you had a lesser rate of prostate cancer death. And so that was known. And then what's recent, and when we started these Stop 1 meetings, we didn't know about this stuff. We knew about cardiovascular with estrogens, but we didn't know about cardiovascular disease with LHRH agonists, with bilateral orchiectomy. We always thought that was safe, CAB, and even anti-androgens. And about that time is when the large 150 milligram Casodex trial sort of stopped, and largely because of cardiovascular events in the Canadian cohort of that study. This was already mentioned by Bertrand, these pooled analysis, and this is one that there have been a lot of studies done with degarelix as an antagonist, and comparing it to either goserelin or luprolide most of the time. And this is a sort of a meta-analysis with all the downside of a meta-analysis and looking at outcomes, but it looked at a pooled analysis to look at cardiovascular. And if you looked at men who had baseline cardiovascular disease, and Alex already pointed this out, that's the risk factor, that was in the ARS question, what we know is that there was a difference in cardiovascular events between men treated with degarelix versus luprolide acetate. So that was one of the first things, and that was a couple years ago that Peter published this. Now, what are the possible mechanisms by which this occurs? I think there are 3. One is metabolic status. 2 is exacerbation of underlying cardiovascular disease. And we'll talk a little bit about some of the exciting preclinical data. So let's talk with metabolic status. We all know about metabolic syndrome. We've mentioned a little bit earlier about testosterone and low T can lead to metabolic syndrome. It's unknown whether giving T back actually corrects it. A lot of people think so. Other people are not so sure. And then there's the metabolic changes, not the metabolic syndrome, that occurs with ADT. And it's different. The difference is that in both of them you have increased triglycerides, increased visceral fat, which is the bad fat, and with ADT it's subcutaneous fat. You have reduced HDL with metabolic syndrome and increased with ADT. And then adiponectin is increased, so more fat deposits, and then your C-reactive protein, sign of inflammation, higher here, normal here. And the issue is there really an increased rate of cardiovascular events in men who are on ADT? Well, one of the things that we do know is low testosterone is implicated in metabolic syndrome. ADT, by definition, reduces testosterone. So is low testosterone associated with metabolic syndrome? I already showed you there's some commonality, but there's some things that aren't. And the other thing is that long-term ADT, you probably become sort of stable, and the cardiovascular risk actually occur quite early, within the first 3 to 6 months. At least the incidence of that is high, and that's been seen in a number of different studies. So what's the second mechanism? And that's the exacerbation of underlying cardiac or cardiovascular disease. So what we're saying is the reason it occurs quickly is that something happens that you stir up what's already there. You know, for this to happen very quickly, for a plaque to develop and so forth, takes time. So it must be something that is present that you exacerbate. And so we've already heard about this. There's sort of the good plaque and the bad plaque, so to speak. The stable plaque and the vulnerable plaque. And so the stable one is a thick plaque. The cap is thick, that surrounds the lipid core. It's rich in smooth muscle and matrix, whereas the vulnerable plaque has a lot of inflammatory cells, proteolytic activity. It has more lipid and compared to the stable plaque, and it exhibits more inflammatory activity. So it's sort of like a prime explosion ready to go off. It just needs something to activate it. And the thought is, and again, now we're getting into the hypotheticals, and we're getting into laboratory studies in mice and under conditions that are manipulated, so to speak. So what it's worth, we're going to try to define it. So one of the things that happens is that T lymphocytes create inflammatory reactions. And if you have T lymphocytes that are in the plaque and activate it, and you have things sort of happen to the plaque, it becomes unstable, then you can have a thrombosis, or you can have a rupture of the plaque. And so these cytokines that are released by the T lymphocytes can have an effect. So is there a difference between agonist and antagonist? And again, there are some studies that have been shown, Shin and others have shown, a couple, that on T cells, there are GnRH receptors. And that, hypothetically, a agonist actually may stimulate the T cells, cytokines, and then in an unstable plaque promote plaque instability and rupture, whereas an antagonist on T cells has no increased proliferation and activity. So this is one hypothesis. Not a lot of people, not everybody believes this. There are other people that believe FSH plays a role, and I'll talk about that in a minute. So let's talk about some preclinical data. Now we're going to get into some of the rodent models and things like that. This was a very nice study done by Knudsen here in Europe, taking rodents and sort of challenging them with cholesterol-rich diets, stress and things like that, and then treating them with an antagonist, decarelix, leuprolide, or untreated, and then looking at plaques. And what you see here is, if you look at the untreated, that's been cholesterol-fed and stress-modified, and the leuprolide treated artery, what you see compared to decarelix is increased necrosis and inflammation in both of these, particularly more pronounced in the leuprolide-treated animal. Then the group from Canada and others have looked at differences in FSH and LH levels. And Yanni Pinthus, who works with Laurie in this group, and then Canadian group up there, is sort of sold on FSH. And I actually believe this too. We have a couple manuscripts out on FSH. FSH is probably bad in certain circumstances. And FSH and LH levels are lower on an antagonist than they are with an agonist. And actually, the highest FSH levels you get are with bilateral orchiectomy, which may explain some of the cardiovascular stuff that was seen with bilateral orchiectomy in the slides earlier I went through. And what they did is they looked at weight gain and other things like that, and plaque areas and so forth. And what they saw was, necrotic plaques and total plaque areas here, and these are the necrotic plaques, much less with degarelix than with luprolide or bilateral orchiectomy, and degarelix was almost similar to control, so it's there. So other studies have looked at some other knockout mice and ApoE deficient mice, and looking again at luprolide and degarelix and the effect on these mice and atherosclerosis in the aortic root, and again showing that there is a difference. So, the mechanism of ADT and cardiovascular is interesting. There clearly is, and we've shown this in studies that Bertrand already alluded to, that there is a more rapid suppression of FSH and LH and testosterone with degarelix versus agonist. You don't have microsurges or what's called acute on chronic, and I believe this is a significant issue. This is why I believe, and I told Dr. Klotz this a long time ago, we talked about it at lunch today, that I believe there is an increased risk of cardiovascular events in men on intermittent therapy. And if you look at their studies that were done, there actually were less deaths from prostate cancer, much like the estrogen thing, and I think people are beginning to recognize that as an issue. And so microsurges, because many of these drugs are not 3 months. They're not 90 days. They're 81 days. They're not 30 days or 28 days. And the same way with the 6 months, you have bare naked receptors, and you had this acute on chronic thing that occurs. And so there is a difference, I think, between this and FSH and many other things that happen. So, again, there are some benefits of antagonist over agonist, as you've already heard. So what does this mean to my patients from a perspective of a urologist? I consider the therapy when I treat the prostate cancer, and ones that rapidly reduce testosterone and FSH and LH, controlling symptoms and minimizing effects. I think this cardiovascular thing is real. I have seen over the years many patients I've treated with hormone therapy. They're in their 70s and 80s, and they're doing okay, and they just die. They have a heart attack and die, and it's, well, that's just old age. And, and you see this enough and enough and enough in healthy people, reasonably healthy people. It raises your suspicion that this is something that can happen. So this cardiovascular risk is something real. Right now, it's being studied, as it was already mentioned. So I put this together a long time ago, and the teeter-totter has changed a lot. I mean, there are clear advantages of agonists. The big ones are that you have long-term formulations. You have 3 months, 6 months, 12 months, whatever. And then probably you have fewer injection site reactions. But there are all these things that appear with antagonists. And this is not only with degarelix. This happened earlier. Some of these things were seen with aberelix, the drug Mark Garnick's company developed with Praces. And you have the FSH is down. The PSA goes down quickly. We didn't talk about alkaline phosphatase. We didn't talk much about surge, but cardiovascular risk are something that are real. So in summary, ADT associated with an increased risk of cardiovascular events. I think most people would agree to that. There is a trial that is going on right now called the PRONOUNCE trial, which is looking at degarelix versus luprolide and looking at cardiovascular endpoints. I think there's a lot of immunological issues that occur here that may explain the reduced rate of cardiovascular events, and As Alex said, risk assessment of cardiovascular disease needs to be done prior to using ADT and during ADT, which I learned from him today.